Wait. Assalamu alaikum. The short clinical day. First scenario, Miss Sarah, 40 years old. Please examine the patient appropriately. Neurological or nervous system. Okay.
Okay.
Here you go.
All right. Hello there. I'm Dr. Aisha, one of the medical doctors here at the clinic today. Could you please confirm me your name and age?
Yes, I'm Mr. Sarah Ahmed, or Miss Sarah Ahmed. I'm 40 years old, female.
So, Miss Sarah, I've been asked to examine you, especially your eyes. During this procedure, I'll be asking you to do some movements, and I'll be touching your face and the other part, and asking you to do some movements, and I'll be doing some movements. Will that be all right with you?
Yes.
During this procedure, if you feel any pain or discomfort, please do let me know.
Okay.
So,
Can
Miss
you
Sarah,
share? I have the picture for the patient. Just a minute.
Yes, I'm sharing it. So you can start the sterilization. Wash your hand.
yes, yeah, I wash my hands and
Yeah,
I'll go towards the
exactly.
patient.
Yes. Some instruction to the patient. You finish. This is the picture of the patient. You can start examining now. You can see it in the chat box.
Okay.
You could, yeah.
So, I will see, is there anything around the bedside that I should notice? Is there any aids for her that she
No.
has? No, nothing. Okay, no walking aid, no nothing. Yeah. Okay, Miss Sarah, um, I'll start with the eye. So I'll be doing the fundoscopic examination first. With the fundus, I will be seeing any signs of papilledema.
No.
No. Externally, I will be seeing the eye. The eye is drooping. One of the eyes has have ptosis, right? One is a drooping eye. Any
Yes.
twitching or fasciculation that I can see around the eyes?
What?
Any twitch or fasciculation around the eye?
No.
Any rashes around the eye or any color changes that I should notice?
No.
No. Okay. I will. Miss Sarah, do you feel any tearing of the eye or any redness?
No.
During my fundoscopic examination, I will give the chart to read for the vision. Can you read the chart?
Yes,
The
I can
last
read.
line properly?
Yes.
I will give the color saturation for Ishihara test.
Normal.
Normal. Okay, I will check for RAPD. I will swing the light on both the eyes and see the pupillary response. Is there the response proper?
Normal.
Normal. Okay. Then I will go for ophthalmic exam for the cranial nerve 2 to see any optic nerve changes that I can see. Cranial number 3, 4, and 6. I will go for cranial number 3, 4, and 6. I will ask the patient to move towards the right. Then go up.
Number 1, 4.
Yeah, 3, 4, and 6.
Yes, there is some weakness in the lateral gaze for the
Okay.
medial rectus.
Okay, medial rectus has a gaze. Now I will ask the patient to see to the extreme sides. Which side is the gaze pulse? You're saying both the sides?
Both that, yes.
Right and left, both the sides?
Yes, in the lateral
Bilaterally?
rectus.
Okay. I will ask to see to the extreme side. Is there any nystagmus?
Yes, in the abducted eye.
Nystagmus in the abducted eye, yeah. Okay, I will ask the patient to. Now I'll be checking the cranial number fifth in all the different zones, the trigeminal, uh, all the three, the temporal, the maxillary, and the mandible branch. Is it
Normal.
normal? Okay, I will be checking for cranial number 7, cranial nerve 7.
There is weakness.
Okay, and is it the weakness is bilaterally?
One
Yes,
minute left.
bilateral.
Okay, I will be checking the. Okay, 1 minute left. Yeah, I'll be checking the limbs. Is there any change in the tone in the limbs?
There is proximal weakness.
Proximal weakness. Any is I will be checking for position and vibration.
Normal.
Any wasting muscles I can see.
No.
No. Okay. I would ask the patient to could you please stand up and walk for me, please?
Yes, I feel tired, doctor.
You're
It's
tired.
working.
I'm very sorry to, but could you try to walk? Is walking okay for you?
Yes, but
Could
only
you
fatigue.
only tired? Could you cross your hand and stand up from the bed?
Cross what?
Cross your arms and try to get up without buckling your
Yes,
knees.
I have some weakness. I have difficulty with this.
Okay, getting approximate. Combing hair is a problem for you.
Yes.
Can you unbutton and button your shirts?
Okay.
I can. Yes, normal.
Okay. Time is up. Yeah.
Okay.
So you can just collect your thoughts. What do you think the case is? Your differential. Quickly, I will give you just maybe a few
Yes.
seconds.
Yes, my differentials. The
She will
positive
ask you.
finding.
She will ask you
Oh,
now.
okay. She will
Yeah.
ask me. Okay.
I want you to collect your
Okay.
thoughts. What positive?
Mm.
If you're ready, we can start.
Yes, sir. I'm ready.
Okay, here you go.
Okay. Tell me what is your finding in this patient?
Okay. So, Dr. Sharma, my positive findings, I will say that the patient has a internuclear ophthalmoplegia. That is, he said that when he takes one eye towards the extreme side, the other has a midline problem, and the side that goes to the extreme end is having an nystagmus, and one eye cannot pass the midline. So I feel there is the MLF type of lesion which I can notice in the eye. I could see by the picture that there is ptosis
Yes.
in the eye. The eyelid is drooping down. The other positive finding when during the examination, the patient said that she has proximal weakness and difficulty getting up without buckling or without the support. Uh, in in the eye examination, there was nothing else that I could find which could help me with other indications like no papilledema or anything. Taking all this into account, my one of the differentials would be um, multiple myasthenia gravis, and
Okay.
the other differentials because it has a lesion in the brainstem. I would also keep multiple sclerosis as one of my differentials, though it will need more of my physical examination and neurological examination to come up with the diagnosis. Um, uh, the other differential, I would be saying that it will be um, yeah, myasthenia gravis, and yeah, I think these two are my top differentials.
Myasthenia
Or
gravis. Other differential?
yeah, the other differentials is of course multiple sclerosis. I said, and any other tumor or vasculitic type of lesion could also be in my differentials.
Mm-hmm. Okay. So, what investigation you will do for this patient?
Yeah, I would start with a bedside investigation of complete physical and
Hmm?
yes, Dr.
What
Simon.
important thing in this patient you need to see is
Yeah,
very critical.
yes, my patient has a ptosis, unilateral ptosis, or it's bilateral. It's a bilateral
There is
ptosis.
bilateral tones, but
Bilateral
asymmetrical.
ptosis, yeah, but asymmetrical, yes. So I will be doing the EMG, and in EMG I will be seeing the easy fatigability of the patient's eye, which will help me to come up with the diagnosis of myasthenia gravis. But as
Mhm.
my yeah, because I kept my differentials as multiple sclerosis as well, so I would like to do the workup for multiple sclerosis as well.
If we said this is myasthenia gravis, what investigation you will do?
Yeah, I will be doing the antibody test, like anti-musk and anti-acetylcholinesterase antibodies. I will be doing the adrophonium test just to provoke and see is there any easy fatigability of the nerve muscles. And at the end, to confirm my diagnosis, I will be doing the EMG studies.
Mhm. What is vital test you have to do for this patient?
Antibody test.
Okay. Is important bedside test.
The respiratory test.
Okay.
Uh,
Right.
um,
What we
How
call
you
it? What we call it? This respiratory test.
and the FPC, the peak flowmetry or spirometry,
To measure what?
to measure the functional capacity, vital capacity of the lungs.
Forced vital capacity. Okay.
Uh,
Continue question, Dr. Shaima.
okay? Okay. If uh, I think okay. What is the treatment?
Yeah, the management plan.
mm, the management plan will be the multidisciplinary team, of course. We will be needing the rheumatological doctors, as well as we will be treating him from yeah, we will be needing specialized nurse, and uh, yes, we will be needing physiotherapist. These will be the we will go with the non-pharmacological and pharmacological approach. In pharmacological, we will be using acetylcholinesterase inhibitor drugs like pyridostigmine and neostigmine, physiostigmine, um, and for supportive, if there are any, yeah, that will be that's yeah, that will be my treatment.
Only acetylcholine receptor inhibitor. Acetylcholine
Uh,
receptor inhibitor.
yes.
What if
Yes, I
the patient has complication like respiratory muscle weakness? What will be the management?
uh, yeah, I will be giving the supportive oxygen therapy, and the physiotherapist will be included. Um, drugs like LM2. Uh, no,
Where you admit this patient?
I will be admitting this patient in the ICU if he's in the acute. If yes, okay, let's go. If it is an acute condition, I will start with a high dose of
Yes.
steroids and
Perfect.
yeah, and try to bring him out of the exacerbation. And for the maintenance therapy, I will start with the acetylcholine esterase inhibitors and other disease modifying drugs. I think
Okay.
is
Okay. Thank you, doctor.
Okay, when you admit the patient to ICU,
when he has the respiratory difficulty, or when there is the signs of infection, or poor, or yeah.
Give me
Or
parameter to admit this patient in ICU. Is there a parameter you will admit him or you admit her?
no, sir, I don't know about that.
You mentioned the
Yeah, the
force
force
volume
volume,
capacity.
yeah,
Yeah,
force vital capacity, but I don't know. I think less than
force
40,
vital capacity. Less than 20.
less
Less
than
than
20.
20 should be admitted to ICU. Less than 15 need intubation, right?
Okay, okay, less than 20 in
Force
ICU,
vital
and
capacity. Yeah, 20 ml per kg or less than 15 to be intubated. Okay, you mentioned steroid. What other options you can do? Give me one more medical and another surgical.
uh, um, if the patient is mm,
As a procedure, any procedure you can do.
in myasthenia gravis,
Yeah, myasthenic crisis.
mm, I cannot recall now.
What we call it? With line. Will you do plasmapheresis? Is
Yes,
it effective?
plasmapheresis and IVIG. Yes,
Okay.
yeah, we can do the plasmapheresis and
This
IVIG in
is
the.
another medical option. What the last, not definite, there is surgical option. What you can do as a surgery. If you have evidence of what, you will do what? If you have
Uh,
thymoma, what
yeah,
you
we
will
can do
do?
thymectomy. Yes, and I will be
Yes,
doing the CT scan for. Yes.
exactly. So you will do first, if there is evidence of thymoma, you can do thymectomy, particularly in young patient. The last question, what types of myasthenia you know?
I haven't touched this topic. So, um, no, I don't know.
Do you have an idea
I
about ocular and generalized?
Yes, ocular is the one that will be having mostly the ocular type of symptoms, and the treatment will be high doses of steroids to prevent or the
So you have
the which
ocular and you have generalized, right?
generalized fatigability.
This is
And
my question. Okay.
okay.
Okay, 10 minutes enough for you today as a first attempt.
Yes, sir.
Dr.
Very,
Shima
yeah.
will comment. Prepare your case,
Yes,
Dr. Aisha. Prepare it, okay?
yes, sir.
Okay, you can start now, Dr. Shima, the case, the performance
Uh,
as well.
okay, I think regard I don't know
Yes,
يعني
yes,
لا
Dr. Sharma.
yes I will you want from me to comment on her
It's very
صراحة ما أعرف
unsatisfactory,
أنا
but yeah, I know
no you did well maybe because
the panic.
you said you think this is unilateral to this maybe this make confusion for you
Yes, because I
uh,
could see only one eye drooping, so I was thinking maybe it is a um, because it's only one eye in the picture. You can't like see the complete ptosis, right? So I thought maybe there is a compression syndrome which is causing the like a Horner or something. So if it is a unilateral, so I was thinking on that side that maybe the Horner syndrome, or there is some ganglionopathy, like jugular vein ganglioma, that is compressing the the ciliary ganglia and causing the ptosis. So
uh, but I think
yes,
you have to put
yes,
the differential of myasthenia
yes,
gravis if you see any patient with ptosis.
yes,
Also, but you have
yes.
to start by, I
Mm,
think, checking the fatigability for the eyelid by asking the patient to look upward for and counting. The ptosis will be worsening.
mhm,
Also, facial weakness, and ophthalmoplegia, and this patient has pseudo internuclear ophthalmoplegia.
I know, yeah.
Yes, and also ask him to smile, snarl smile for myastheniographies, and assess the sternocleidomastoid, the neck muscle weakness, and also the proximal muscle, upper and lower. What else? Okay, and then search for thymoglobin scar, and ask for vital sign, oxygen spirometry. I think yes, and also check palatal weakness, and you can hear the patient voice if there is any nasal quality speech. I have to comment.
Yeah, Dr. Shaima, what's the differential? Tell her.
Lambert-Eaton syndrome is the first differential.
The first is what? Myasthenia?
Lambert-Eaton.
Lambert-Eaton, yeah.
Okay.
Also,
Why Lambert-Eaton as a top differential?
because it came with similar presentation.
You mean myasthenia first differential, then the Lambert-Eaton, right?
Yes.
Okay, the third?
The third can be
What can cause ptosis?
third nerve
Botulinum toxin.
What?
Botulinum toxin. Yes, botulinum toxin itself will also produce the ptosis and
Okay.
myasthenia type of picture with the no.
But yes, it will be weakness.
Yeah, weakness.
Generalized
Yeah.
weakness, yes.
Yeah.
Okay, what other differential with ptosis?
third nerve
Yeah.
palsy.
Third nerve palsy? No, there was no ptosis in third nerve.
Horner syndrome.
Horner syndrome,
Anything
yes.
that is
Horner.
called
What
Horner
else?
syndrome.
One more,
else?
it's important in PACEs. It comes as short
Any
and
aneurysm, aneurysm in the pecon, the posterior
it comes as
circulation.
short and it comes as long. Very
Here,
important.
myotonia dystrophic.
Thyroid,
Yes.
thyroid diseases.
No, myasthenia dystrophic.
Myotonic, yes, myotonic dystrophy.
The opposite in the grave is the opposite. The eye will be, the lid will be retracted, and the
Yes,
eye
sir.
will be out. Okay,
Exophthalmos.
exophthalmos, but not as ptosis. Ptosis is myotonia dystrophica. Okay.
Dystrophic. Okay, sir.
Yeah. Okay. Continue, Dr. Shaima. What other comment regarding the investigation? What she mentioned, what she missed?
Okay, regarding investigation, you will do a basic investigation and also antibiotic against acetylcholine receptor antibody, and the vital or forced vital capacity, on CT chest for the thymoma.
Yeah, for thymoma.
Yes. Regard the management اللي هو non-pharmacological supporting and counseling the patient regard his disease, and pharmacological treatment by giving him acetylcholine esterase inhibitor like pyridostigmine, also steroid. The main treatment are steroid, most commonly used agent. Plasma exchange will be safe for the myasthenic crisis not respond to steroid or if steroid sometimes
Resistant.
can worsen the condition.
Mm-hmm.
Why? What it can cause? If you start through, what will happen? What we call
Steroid,
it? Yeah, it can cause relapse,
yeah.
weakness, severe weakness, and what we call it? Steroid dip.
Yeah, the,
Okay, you have to know
yes.
this. So whenever you are planning to start steroid, you have to admit the patient. Monitoring of worsening weakness. Okay, what
Yeah.
else?
Also, intravenous immunoglobulin.
Yes, IVIG. Okay.
Mm.
And you mentioned already thymectomy. Okay. What are the multidisciplinary team approach in this scenario you can involve? Very
Is it
important.
for
Yeah.
is it for me? So
Okay, you mentioned it.
yeah.
You mentioned already, but I want Dr. Shema to give me the full team because she's the one
Mm.
prepared the case.
Yes, will be the neurology team, pulmonology team,
Okay.
uh, and physiotherapy and occupational
Perfect.
therapy.
Yes, occupational therapist. What else? Respiratory therapist,
Yes,
right?
yes,
Mm.
And also nephrologist if you are planning to do plasmapheresis. Surgeon in case of thymectomy, the for indication of thymectomy. Okay, let's add one more question here. Yeah, what is the specific test to is investigation and to diagnose it? By the way, hydrophonium test is not anymore than Dr.
Used, yes.
Yeah,
Yeah,
okay.
now it's not used, yes.
Yeah,
But
so don't
that,
mention it. You can
yeah,
mention previously forming doing this test, but nowadays they are not using this test. But don't
yeah,
mention it. You can mention
yes,
the EMG or single fiber EMG, right?
yeah,
The
yes,
antibodies already. You
monofiber.
mentioned, yeah, you mentioned the antibodies and the forced vital capacity, ABG, as well as the pulse oximetry, chest X-ray, CT. In
Yes,
order,
sir.
you can say in order: general
Mm.
investigation, specific bedside test, and imaging ended by the invasive test.
CT. Yeah, okay.
Imaging, the for the diagnosis, but invasive, you might do some invasive like bronchoscopy, or you might do also CT or thymectomy as a surgical intervention. Okay, let's go to the investigation. Sorry, the management plan. You mentioned all, but before mentioning how to treat myasthenia, you have to speak about what are the possibilities of presentation. Every myasthenia patient, how he can or how she can present. Is it usually as a cold, chronic case, or it can present as acute? It will be
It
totally
can
different.
can present with
yeah,
acute.
Yeah, so better to start in this way. So, in order to manage this patient, either patient will present as acute or chronic. In the acute form of the disease, how you can start managing him? Give me approach.
ABCD approach.
Exactly. So I will start with the ABCD approach: airway, breathing, circulation, and of course, multidisciplinary team, including the respiratory therapist, pulmonologist, rheumatologist, a neurologist, sorry, and for possible ICU admission, whenever the forced vital capacity less than 20 should be monitored in the ICU. And for the crisis, if patient diagnosed as myasthenic crisis, we can consider plasmapheresis and IVIG to control the crisis. A very important point, Dr. Aisha. I will ask you this question is very important. What counseling and education you have to tell to this patient?
yeah, the falls are very easy, like and the patient can. It's I will explain the fatigability and the progression of the disease to the patient. And
Yeah,
am I
what
going in the
else?
right?
What is
Yeah,
very important you have to mention to this patient?
Drug, there is some drug can
Is it
worsen
only
interaction.
it.
drug? Is it only drugs, or you can say I will speak about triggers, right?
Yeah, what can trigger the
Exactly.
crisis?
Yeah. So what are they?
Yeah, what can trigger the crisis?
Yes, it's
Um,
very important. Important to know and to inform the patient. Give
if
me
drugs can
example. Yes.
drugs
Okay.
like
Perfect.
amiodarone and any antipsychotic drugs. Um, mm,
Give me the most common.
uh, the most
Give me
common
the most common antibiotics.
uh, antibiotics.
Okay. What
Yes,
are
sir.
they?
Like ciprofloxacin,
Yes.
the
Yes.
macrolides. They can,
Quinolones,
yeah,
aminoglycoside,
yeah,
bucanolones,
yeah,
tetracycline,
tetracyclines. Yeah, macrolides can do that.
macrolide. Okay.
Antifung. Yeah, mm,
So you
yeah,
can say drugs, for example, antibiotics, and as you said, some of inhalation or anesthetic, right? So antibiotics,
yeah.
starting by antibiotics, and anesthetic medication can also worsen it.
Hmm.
I think also beta blocker, if I'm not.
Yes, yes. So beta blockers as well. Yes, beta blockers can provoke myasthenia gravis.
Okay,
And
and you have to mention the infection itself. So the infection can precipitate, or the drug as antibiotic can also precipitate. You have to speak about both of them. Infection, stress, before mentioning the drugs.
yeah.
Okay.
Okay, sir.
Okay. This is regarding the precipitating factor and how to manage by counseling the patient about these things. Okay, if you have a long case scenario with myasthenia, what's important to counsel about? Any other
Preg-
advice you want to give?
pregnancy, driving.
Perfect,
Um,
perfect. This is what I want to say. Yes. So the driving is very important to ask. Do you drive? And you can give him advice or her advice regarding driving. Inform DVLA. Pregnancy. What the importance of pregnancy?
the drug interaction, the drug,
Exactly.
yeah,
The drug side
that can
effect,
cause, yeah, yes, that can
steroid or
cause
steroid sparing agents.
yes, and also like it can cause osteoporosis because she is on steroids most of the time. So
So you
um,
will speak about steroid and the side effects of steroid.
yes,
Yeah, you have to counsel about it. But I want to speak about driving and pregnancy whenever you are talking in long clinical consultation scenario. In short, you will not ask the patient, but you can say one of the advices I should give advice regarding these things, driving and
hmm,
pregnancy. Okay?
yes, yes,
And
sir.
some counseling education about the triggers. Patient should avoid any triggers. Okay, I will comment about the performance. Of course, as a first time, I will not be too much detailed because it will not be in this way next time. You are little
Sure.
bit disorganized, right?
Yes,
So
sir. I think the stress because of
yeah, sure, sure.
presenting.
I'm not commenting to say it's negative or it's bad performance. No, I'm saying how to do it in a good
Yes, sir.
way, organized one. Whenever you have
Yes.
eye examination, start to
Hmm.
examine in this mnemonic. You can
Yes, sir.
write it down, or I will write it down in the chat box. So we'll start with Afro. A for acuity,
Uh-huh.
F for fields, R for
Field lesions.
reflexes. I'm writing them in the chat, but you will see them in a minute. And O for ophthalmoscope, which you started with. It's supposed not to be at the first.
Okay.
It could be at the end after finishing the other steps of
Okay.
thermoscope. One more Afro H for H shape movement.
Yeah, for 3, 4,
So
and
Afro
6.
H, okay? H shape.
Yes.
These are the examination
Mm-hmm.
of eye, any eye case. What else? If you want to examine, if you have patient with ptosis, as you say, as you saw in this scenario,
Mm-hmm.
eye examination you have to do. As I mentioned, Afro H shape.
Mm-hmm.
After that, so what are the differential of ptosis if you have patient with ptosis? I suspect,
I
as I
yeah,
said,
Yeah,
right?
for myasthenia gravis, yes. For
Tell me
myotonic
yeah.
dystrophy,
No,
uh, uh,
let's talk about myasthenia. What are the tests or the examination to do for myasthenia gravis? And you have to fulfill in the exam these tests. What you have to do? You didn't do in this
uh,
today.
the fatigability test, like,
Exactly. Yeah.
yeah, the
So
blinking of,
how to do the fatigability test?
yeah, asking the patient to keep it eye and look up
Perfect.
for 30 seconds, and then if there is a drooping, or I
Yes.
can see the eye is not holding the position, so it will be a
Exactly.
positive test.
This is
Yes.
fatigability. And at the same time, you can ask the patient count for me from 1 to 20. So
Mm-hmm.
you do both tests together, fatigability, and the
Mm-hmm.
same time you will find patients having nasal tone in the same time because you don't have long time to examine the patient, 6 minutes only. So I
Yes.
can give him two instructions: look up and count for me from 1 to 20.
Mm-hmm.
The counting tone will be reduced and it will be nasal tone, and the
Mm-hmm.
eyelid will be dropping as well as for the eyeball, right?
Yes.
Okay, this is for the eye. What other specific tests you have to do in myasthenia patient apart from the ocular fatigability?
Yeah, the proximal weakness test for the
Exactly.
tone. Yeah, and
Proximal
yeah,
weakness.
power. Yeah.
Okay. So, so to do it, you have to do the ocular fatigability and the fatigability for the generalized myasthenia. How to do the fatigability, the generalized one
L- Uh, the
for
EMG
proximal
test.
myopathy? For proximal myopathy.
Yeah, asking the patient to do the, like,
Yeah,
uh, yeah,
abducting the arm,
yeah, abduct. Yeah, abducting or
abducting
adducting.
both arms,
Uh,
but he will move
yes.
in count from 1 to 20, one of them, either right or left. Can you move your arms by doing abduction, repetitive movement of abduction, adduction,
Mm-hmm.
and later on, after finishing the counting, you can compare the proximity between right and left.
Yes. Yes.
You got it?
Yes. Yes.
Okay, or by doing the thigh flexion.
Yeah.
So you ask the
Yeah.
patient to
Telling the
sit,
patient to.
yeah, and also ask him to move one thigh as flexion repeatedly. Then
Mm-hmm.
compare the flex the weakness or the power of both muscle in both thighs.
Both the
One
ways.
of yeah, one of them will be weak, the one with the repetitive movement, and the other will be still maintained. This is
Mm-hmm.
regarding the fatigability test. What else if you suspect? This is for myasthenia. Let's talk about the other differential for myasthenia. As I mentioned,
Like, yeah, like myotonic dystrophy, right?
yeah. So,
Um,
what is the specific test for myasthenia gravis for myasthenia dystrophica?
we'll be doing the gene test and
No, no, not
dystrophin gene.
investigation. No, I'm
Uh,
talking about examination.
Examination.
Hmm.
Of course, I will be first looking at the face. Is there any changes, atrophy of the muscle? In the eye, you can see the cataract.
Okay,
There will be muscle balding. This is what you
okay.
mean, sir?
This is
Or,
by inspection. Yes, this is by inspection. Okay, what else? Give me
yeah.
specific examination.
Yeah. There will be proximal muscle. There will be wasting of the muscles. Pes
Okay,
cavus could be seen, like
okay.
um, some, and it's a this in the grip, hand grip will not be
Exactly, yes. Hand grip.
released.
This is what I want you
Yeah.
to say. So the hand grip and myotonia percussion. If you do percussion myotonia at the
Yeah.
area of
He,
the base
yeah,
of the thumb, they will have flexion in all fingers.
yeah,
And the
yeah,
myotonia grip, you will ask
yes,
the patient to grip on your hand and he will have very slow release or relax.
release, difficulty
Okay?
of release. Yes, sir.
Yeah, so these are the possible differential in ptosis. Whenever you have patient with ptosis, you have to do these tests in 6 minutes. Commonly, I'm not saying this is the all, but this is the most important to do. Okay, cranial nerve, yes, you have to choose one cranial nerve to do, as you did, facial nerve. But I don't know why Dr. Shayma said there is
Yeah,
facial nerve palsy. Can you tell us, Dr. Shayma?
yeah,
لما تكون عندهم facial weakness, bilateral facial weakness,
So
يكون
it's
عندهم
not
حتى
it's not cranial nerve injury, right?
yes,
Not as a
yeah,
cranial.
muscle.
Yeah,
yeah.
okay.
That's why
Yes.
when Dr. Sharma said that,
But I
I
said
had
the bilateral weakness.
palsy, so I started that
Yeah,
maybe it
that's
is
why. Yeah, it's
yeah,
confusing.
multiple sclerosis because
Yeah.
there is seventh nerve involvement there.
But even multiple sclerosis will not be as lower motor neuron lesion. It will not affect the seventh cranial nerve. It will affect the brain stem.
Fifth, yeah,
No,
yeah,
even not fifth. It will affect the brain stem as upper motor neuron lesion. Okay. Yes, it might affect
yeah.
the nucleus, but it's not affecting the nerve out the brain stem. You got my point. Multiple sclerosis is presenting as upper motor neuron
Central,
lesion. Central, yes,
yeah.
it's not a features of lower motor neuron lesion. Clear for all?
Okay.
لأن ال OST يعني كاتب إنه bilateral weakness of facial muscle is almost always present.
You can say patient is having what's called the myasthenic snare.
Okay.
Yes, myasthenic snare or
Yeah.
face, characteristic face. When I ask him to smile, he will have what we call myasthenic snare. This you can
Yeah.
mention, but you cannot say a generalized facial weakness. It's characteristic feature or characteristic features. Okay.
Mm-hmm.
The salt team we didn't mention is very important. Swallowing and language therapist are very important team to be involved because those patients also they have some choking and difficulty of swallowing, right?
Yeah.
Okay,
Yes. Yes.
I am done with
Okay.
my comments. Anyone has question? Dr. Sarah, sorry, Dr. Shaima or Dr. Aisha?
No, sir.
No.
Any question
No,
or any comment?
no.
Anyone want to add any comment before starting the second case? I will read the comment quickly. No facial, Dr. Soha. No facial in myasthenia gravis. Yes, facial, I think, as a part of general weakness. As I said, it's characteristic features, not as cranial nerve. Yes, you're right. It's not facial nerve. It's facial weakness or all generalized muscle weakness. Yes, you're right, Dr. Soha. Dr. Samira. Myotonic grip, myotonia percussion. Yes, we mentioned it. Thank you. Grip for myotonia. Yes, yeah, this is very important to know this mnemonic. Whenever you have any vision affection, you have to go through these steps. Don't be confused. What I do now, what should I do? You have to do
Mm-hmm.
this IQT. So you ask the patient, can you see that if you have snare chart, you can ask. If you cannot, you can ask him by counting the finger, three or two or four. If he cannot see, you can ask him, do you see the light? Of course, after covering one of his eyes. Okay.
Yes. Yeah.
Then examine the other eye. Alternatively, the field, as we know, you will cover your eye in front, the
Yeah.
eye corresponding to his eye. So he will cover the left, and you will cover your right, and sit in front of him 1 meter apart. Ask the patient ask to notify whenever he see your hand is moving or your finger is moving, and you will come from all quarters, the upper, the lower, temporal. Then you will change your hand covering. Then you will come from the nasal field. As you know, I think all of you know
Yes,
that.
sir.
So this is for the field. The reflexes, as you did, the pupil reflex you have to do, light reflex, as well as for the
Afferent.
uh, yeah,
Afferent pupillary reflex.
pupillary afferent.
RAPD.
Yes,
Yeah.
exactly. Relative afferent pupillary defects. This is for the multiple sclerosis. If you suspect multiple sclerosis, corneal reflex you have to offer, but you cannot do it because it's harmful. And you will
Mm-hmm.
end these steps. The ophthalmoscope, you offer ophthalmoscope. What either the examiner will tell you yes, go ahead, or he will tell you no need. In multiple sclerosis, what do you think the patient will have in ophthalmoscope?
Multiple sclerosis. Yes.
Yes.
There can be if there is optic nerve atrophy, we can see
Perfect.
the
Yeah, this is
pale.
this is what I want you to say. So optic nerve atrophy. Then you will do the H-shape movement. You will ask the patient whenever you feel or you see double, let me know. So you feel pain or you see double. Then you do the H shape as we know. For the supranuclear palsy, Parkinson's disease, you can do the upper in the midline. Otherwise, the H shape will be as H shape movement. Dr. Suha wrote also good comment. Medication, stress, trauma, surgery, infection are triggers. Perfect. So yes, avoid the triggers, avoid the trigger. Dr. Ahmed Mustafa, Dr. Soha, oculopharyngeal muscular dystrophy. Dr. Kani, this is another differential. Yes, the differential here: myasthenia gravis, myotonic dystrophic, multiple sclerosis. I cannot say this is a differential multiple sclerosis, Dr. Soha, because multiple sclerosis usually the patient will have yes diplopia, but other manifestation will be there as upper motor neuron lesion, weakness, stiffness, okay, which is not in this scenario. Graves ophthalmopathy, Graves will be different and opposite. If you want to say ptosis as a differential, you can add Horner syndrome. So our case will be myasthenia, myotonia dystrophica, Horner syndrome as a ptosis. Guillain-Barré, myotonia. Yes, Dr. Soha wrote also
I think
fatigability. Yes,
yeah, the
go ahead.
Guillain-Barré is the one. The
Guillain-Barré also
Miller-Fisher
you can
variant.
mention. Yeah, Guillain-Barré botulism you can add, yes.
Miller-Fisher variant of
But you
GBS.
have to say, I would like to take history. If you
Yes.
want to say this is Guillain-Barré,
Yeah.
supposed to
Yes.
have history of infection and other manifestation of weakness, which is ascending, okay, plus ophthalmoplegia. The last comment, Dr. Soha also fatigability at eyes, H-shape movement, fatigability at shoulder, exactly myopathy in shoulder, examine chest for thymectomy scar, very important, autoimmune screening for thyroid. Yes, I agree to add thyroid as a step of examination if you suspect autoimmune association. So you can say, I would like also to examine the thyroid and scar of the thymectomy scar in the chest just to complete my examination. Okay,
Hmm.
Dr. Aisha, thank you.
Yes.
Let's go to the next. Dr. Shaima, your case is 30 years old lady. Examine her lower limb.
Okay.
We can start?
Yes.
Okay, here you go.
Okay. I will see the surrounding, if any walking aid or food support.
Yeah, there is some walking aids over there.
Okay. Then if any muscle wasting,
Uh, no muscle wasting.
abnormal position,
The position the position is okay. Like what do you mean the position?
if any lateralization in the foot or
No pescators, no.
okay. Any fasciculation.
No fasciculations.
Okay. طيب. Uh, I want now to examine the power.
The power is okay.
The power is okay. Uh, Tone.
The tone is increased.
The tone increase.
Try to mention the steps of power, how to do power examination.
Around for the hip and
It's
around the
okay.
knee,
Yes,
around the
the
ankle.
yes.
It's all okay.
The limb, the leg, and the foot. The power is okay. Mm,
Okay.
Up to
The
five.
tone,
Okay.
I will do rolling for the limb in the
For
knee,
the
in the ankle,
mm-hmm. It's okay,
hypertonia, all
but yes, there is increased tone
bilateral.
bilaterally.
Okay, what about reflexes, knee reflex?
The knee reflex is like the knee reflex is absent, and the ankle reflex is also absent, and the plantars are upgoing.
Plantar upgoing. Okay. طيب, what about sensation?
Um, which one
Cotton wall sensation, fine touch
is preserved?
is preserved.
Mhm.
Pinprick,
Pinprick is preserved.
طيب, position. I will start from the big toe.
It's reduced.
Reduced. What about ankle?
It is reduced.
Knee.
It's present.
Okay. Vibration test.
Yeah, vibration is also reduced till knee.
Till knee. Okay. Coordination. I want from you to
Mm.
bring your heel and
Mm-hmm.
what and move it from the knee
Yeah,
to
heel to shin. Yes,
to ankle bilaterally.
yes. Heel to shin. Yes. Heel to shin without closing the eyes is okay.
Is closing the eye is affected.
Yes.
طيب, I want to can you work for me?
The gait is swaying gait with swaying on one side with it's a staggered, like it's wide based.
Wide base. Okay. Okay. طيب, okay, can you close your eye, please? I will support the patient and be close to him.
Yes.
Positive.
I cannot do it. No, the Rombergs is positive.
Okay. So,
Do you want to check anything else?
1 minute left.
we will check. I will check. طيب, هو السنسوري not affected. Oh,
Are you done, Dr. Shema?
yes.
So could you present your findings?
Okay, on examination of this patient, there is a walking aid beside this patient. There is hypertonia bilaterally with posterior column affection. The sensory is intact. There is a wide base gait. There is ataxia, sensory ataxia. So there is a wide differential diagnosis for this presentation.
So,
This one is vitamin combined combined degenerative spinal cord.
Subacute combined degeneration.
Yes, subacute combined degeneration.
Yes.
And
Um,
also Friedrich ataxia. But
mm-hmm,
again, there is no wasting.
mm-hmm,
Also, I can think about spinal cord compression.
mm,
And
mm.
also, sclerosis can be if combined with peripheral neuropathy. That is all.
So how will you do investigate?
I will do a basic investigation for CBC, urea electrolyte, liver function test, and diabetes mellitus, vitamin B12 and folate level. I will do a nerve conduction study,
Mm-hmm.
genetic test for Friedreich ataxia, and
So for your top differentials, what you want to go for? What is your top? What do you think? What can be the likely of hypertonia with cerebellar signs and dorsal column involvement? What can you think of a disease that has a cerebellar involvement with the dorsal column and the tone is increased?
my top differential.
Hmm. Can it be multiple sclerosis?
Yes, can be multiple sclerosis.
Okay, so if you think multiple sclerosis, what are the tests we should do?
I will do MRI brain and spine.
Okay, all right. What can be the treatment options if
Treatment
it's acute?
option. This depends on the type of the multiple sclerosis. If relapsing remitting type, if there is more than two relapse in the last 2 years, I will start him in interferon beta
Mm-hmm.
or talizumab.
Mm-hmm. What is the side
And
effect of
also,
metalizumab that we think we should be worried about? We should test the patient before starting metalizumab. What are we worried about?
talizumab, they stopped it before, but now I think they said no relation.
AML.
Yes.
Okay. Um. Okay. I think
But I will treat him by non-pharmacological
yes.
by counseling education the patient about his symptom,
Mm-hmm.
um, physiotherapy, occupational therapy,
Mm-hmm.
uh, speech therapy if patient need,
Mm-hmm.
and pharmacological as I mentioned, according to the type of multiple sclerosis.
Mm-hmm. Okay. Anything else you want to add, Dr. Sharma?
No,
Okay. So, Dr. Wasim,
Yes, yes, go ahead. You can comment now.
I can comment. So,
Yes, yes.
y- yes, because I think when we started examination, we were like like even I couldn't understand what she like she wants me to. Maybe because we are talking here, so talking is like not making me understand what she wanted me to do. But the tone, power, reflexes, coordination, and sensation was checked, though I did not understand where she wanted me to answer what. Then walking was there, and when the different when she's talking about the power, we like how much power she's expecting, like over five, what is like how much is the power? That was not mentioned, like over five, over four over five, or is the power of five over five. If we say that, that will be fine. And then when we come for the differentials, I think uh, yeah, differentials was she started with subacute. When she could even do like the complete physical and neurological exam, we could have finished the complete neurological exam, and my tone could be checked because the cerebellar sign is there. So dysarthria, dysphonia, is my speech affected? That could be checked as well. And uh, what else? The other like if she's thinking of Frederick's ataxia, the other things that she would have told me, like I would investigate about the heart as well as for the diabetes, like is there underlying any illnesses. If Dr. Shaima considered Frederick's ataxia as differentials, and MRI was like a giveaway, yeah, and yeah, and I think you can comment better than I can. I think.
No, you did great. Thank you, Dr. Aisha. So it's a case of multiple sclerosis or case for differential.
Yeah, it was a case for differentials, but I just wanted like us to think that if there is cerebellar involvement with dorsal column, and there is a upper motor type of lesion, what we can think of. So yeah,
So let's collect the finding now, me and
yes,
you.
sir. Yes,
Patient
sir.
is having. I want also to teach not only Dr. Shaima how to present and what to examine and how to start examination in any lower limb or neurological examination. So
Yes.
in order,
Mm-hmm.
simply, inspection, of course.
Yeah.
You have to examine the surrounding, anything around, wheelchair, stick, walking aid, whatever. Okay. Then you
Mm-hmm.
will go for the inspection of the limb. The instruction, of course, what I have to examine. I will confirm the patient name, patient age. I would like to examine you today. Please, if you feel any pain, let me know, or my hand are cold or discomfort, let me know. I read
Mm-hmm.
the instruction. Now I will go for the inspection. Anything in wasting, I mean, in the muscle, in the hand, on in the leg, whatever they here in the leg. So I will examine by inspecting the every area by general inspection. If there is scar, viscous, or drop foot, or foot drop, all the things I should pick up by my by my eyes whenever I start examination, even before touching the patient, right? Plus what I
Mm-hmm.
mentioned earlier, the surrounding. This is regarding the inspection. If there is fasciculation, I can see by my eyes, or I can tap on the legs, either the thigh from inner side, both thighs or both legs. I finished the inspection. Now I will examine tone, power, reflex, coordination, sensation in this order. As I mentioned exactly. Tone, power, reflex, coordination, sensation. If you miss this order, you will forget something in between. At the end, of course, you will end the examination by doing the gate. It's very important. Okay, let's start examination now. The tone. How to examine the tone? Dr. Shaima did. Three levels you have to examine the tone. First, the ankle, the knee, or the hip. Either from up downward or from downward up. It's okay. Whatever you start, but do them all. Don't do one of them. So the tone at the ankle, I will move the ankle on all direction. rotating movement. Then the knee, I will ask the patient to feel calm, or yes, to be calm, comfort. Then I will raise the leg from the knee. So I will bend the knee by my hands, and I will notice, is it stiff, or is it lax, or is it normal? This is the tone examination. The ankle as well the same. The hip, how I will examine by rotating and moving the whole leg from the beside the hip. Okay, both
Mhm.
side in comparison. I finished the tone. Now I will go to the power. How to do the power? That's why I'm asking, and I asked Dr. Shema to instruct how to do it. Yes, it's not a real exam, but whenever you are saying, instructing, you will do this in the exam. This is the,
Extensive.
yeah. No, I want to say the aim of doing this online. Yes, it's not like as the real patient, but it's just imagine or simulation. But in order to have more confidence and to know the steps by heart, you have to do them in this way. But you will not, you have to do also the real patient examination. I'm not saying this is enough. No, it can give you more confidence, but not enough to do so. You have to have examination on patient, real patient. If you don't have patient, do it on your any family member you have, your brother, your friend, your sister, your son, anyone in your family. You can do these steps even if he doesn't have any finding. The idea is to gain the confidence. Okay.
Yes.
Now the power. Again, as I said, either to start from up downward or the opposite, from down upward. So if you start from downward, you ask the patient the sole of the feet, so the right and left. Push your feet down and ask him to resist your hand. So you are moving him down. If he has power, he will you will notice. And ask him to raise the feet up and tell him to resist also your hand and push his leg down or feet down. I hope you can imagine it and do it whenever or on yourself. You can do it on yourself while sitting now. This is your first level of examination, the ankle. You can do also for the two. Some candidate or some doctor they are also preferring to do the two extension. Okay, so ask the patient to extend his two up and also do resist this two. Why I'm saying this? This is also for dermatome distribution, but it's not our topic today. Let's go to the next level. You finish the ankle. Ask the patient to raise his whole leg up, whole leg, and ask him to resist your hand. Push him down, and he will raise it up, and the opposite from down, and resist him. Ask him to push it down. This is the level of the leg. Then ask the patient to bend his knees and tell him to flex against resistance and to extend the knees against the resistance. Okay. The last is the thigh, flexion and extension. Ask him to raise it up against resistance, to push it down against resistance, and the adduction and abduction again against resistance. All of them will help you to detect what level of weakness you have, either pyramidal weakness, what the nature of pyramidal weakness. So the whole extensor will be weak,
Mm.
and the flexion of the thigh will be weak.
Sections will,
Yeah,
yeah.
the flexion of the thigh will be weak. He
Mm.
cannot flex the thigh up. Okay, and you can detect also if you have distal or proximal weakness by doing all these levels of motor examination. So in description, while you are saying to the patient, or sorry, to the examiner, what I have features of pyramidal weakness, which is the flexor are weaker than extensor, or I will say he has distal weakness more than the proximal weakness. So according to the level, you have to describe and to say what power is it, 2 out of 5, 3, or 1. So according to your sense, you can identify which level of weakness he has. Next, tone, power, reflexes. Whenever I didn't say about the clonus, it's very important. Whenever you have hypertonia, you
Yes,
have to
very
do
true.
the clonus. How to do the clonus? Raise the leg up and
Yeah.
repeatedly
And
move the ankle. Repeatedly movement, the patient will have tremor, like tremors, okay, in both legs, according to the finding, if you have upper motor neuron lesion. Now the next step will be the tone power reflexes. How to do the reflexes? By tapping, either knee reflex or ankle reflex. It's clear. I think all of you that know them. Then the last one is Babinski. To do
mm,
the planter, is it up going
plantar.
or down going? It's very important to do the planter or the Babinski. It can distinguish between upper motor and lower motor. Okay. Whenever you have areflexia, ask the patient to pinch or to reinforce, to clench his
Mhm.
teeth, or to do you have to do the reinforcement by clenching the teeth. Patient will clench his teeth and repeat the reflex again. The next step will be coordination. As Dr. Shema said, move the heel from up downward
Mhm.
over the shield, the shin in both sides. Once, sorry, twice or thrice. Okay. If he couldn't do this while opening eyes, know that the patient is having ataxia. If he do it while opening eyes, you can do it while closing eyes to check for sensory ataxia. Okay, it's an advanced test. A rhombic test can replace it. So let's move to the next. After doing the coordination, now the sensation. All modality of sensation. We have two superficial, you have two deep. If you have time, you can do all of them, the four. If you don't have time, you can do one superficial, one deep. Either fine or pinprick as a superficial, joint or vibration as deep sensation. Then the if you have the sensation, whenever you have lost sensation, you have to go up one more level. Of course, you are doing the dermatome distribution between both legs as instruction. So you can do start by the dermatome, then you will detect the level if you have the dermatome is intact and there is some sensation loss. You can do the level. If you have, for example, peripheral neuropathy, you have to know up to what level is it stocking distribution or dermatomal or level in the lumbar or whatever the level. You have to know
Mhm.
up to what level. If you have intact sensation, so it's enough. If you don't have or you have sensory loss, you have to know the level. To what level? Even going to the sternum or the chest or the cervical area. Some exam center they have lesion upper in the cervical areas. But it's not topic. Our topic today about upper motor neuron, so it's not sensation or sensory level as a trauma or other causes of sensory level affection. What we have today, it was upper motor neuron lesion, right,
Yes,
Dr.
sir.
Aisha,
Yes,
and
sir.
dorsal column affection.
Yes.
Before ending the instruction, the last thing you have to do, the gate, please walk for
Mm.
me. And Dr. Shaima, you cannot say this is sensory ataxic gate. The patient either to say ataxic gate or high steppage gate. You cannot say sensory ataxic gate. You cannot differentiate
Yeah.
between the sensory or cerebellar ataxia from the gate. You got it, Dr. Shema. So you can what you can mention patients having wide ataxic gait. This is
Mhm.
the description of the gait in ataxia, whatever sensory or the cerebellar center.
Cerebellar.
Yeah. But what to differentiate between or how to differentiate between sensory ataxia and cerebellar ataxia by doing what?
Romberg test. Yeah, when
Perfect.
closes the
Romberg.
eyes and
From the
Yeah,
heel to
Romberg
chin.
test. Hilt chin or Romberg test. Okay. So we
Okay.
are done with the Romberg test.
yes.
Then now the presentation. Don't present like from here and there. You have to be organized while presenting. I examine this lady or this patient. He's having wheelchair. He's having walking aid by inspection. Then present in the same order you examined. The tone was, the power was, and the coordination was, the sensation was, the gait is. In this way. Then collecting this together, this patient is presenting or having features suggestive of upper motor or lower motor neuron region.
Mm.
Typically, in this way, you can get good mark. Of course, if you mention the good and correct finding. Okay, but be organized while presenting. Believe me, the organized way of presentation give the examiner impression that you are confident, you are organized one, you have good knowledge, and you have examined a lot of patients, not only today to examine a patient in the exam. Okay, they want to know if the doctor is having good experience with examination or just he's preparing himself for the examination, for the exam. How to know? By your steps, by your presentation, by your organization. Okay,
Mm.
so let's talk about our case today. It was upper motor neuron region features in the form of hypertonia, hyperreflexia,
Mhm.
pyramidal weakness, right? And
Yes, sir. Femoral weakness.
coordination was impaired because of weakness.
Yes. Yes, cerebellar involvement. Yes.
And there is cerebellar involvement. How
Yes.
to say this is cerebellar involvement from the lower limb?
Yeah, because
Doctor.
the gait
Yeah.
was affected,
Yes,
and
it was wide based gate. What
quite
else?
yeah, and
But by
He
the way, Dr. Aisha,
yes, sir.
by the way, cerebellar affection in the lower limb supposed to be hypotonia, not hyper.
Yes, yes. After I told her, then I was thinking I should have. I wrote it wrong.
Yeah,
Like yes,
yeah.
yeah.
So supposed to have.
But yeah, the tone should be low. Yeah, it should be
Yes,
high.
all will be, it will be like features of lower motor neuron lesion. If you want to say multiple sclerosis with cerebellar affection, the patient will have lower motor neuron feature, not as you
Yes.
mentioned. So your patient will have hypotonia, hyporeflexia, coordination could be impaired because of the cerebellar affection.
Mm-hmm.
Sensation, if the cerebellar if is affected only, sensation supposed to be intact.
Yes, sensation was intact.
But you
Yeah,
mentioned dorsal column.
yeah, yeah. The dorsal column was involved. The pinprick and sensory temperature. The pinprick was okay. It was
So
only
it's
the
not
proprioception.
only cerebellar. So our case today about cerebellar plus dorsal column.
Yeah, dorsal column. I told her in the beginning. I told Miss
Okay.
Dr.
So
Sharma.
in conclusion, Dr. Aisha,
Yes,
because I just try to collect the finding. We have
yes,
lower
yes.
motor neuron lesion features in the form of hypotonia, hyporeflexia, and the coordination impaired because of cerebellar. So all these findings and wide gate based gait, all these features suggestive of cerebellar syndrome. Apart from this, I found sensation impaired in the form of deep sensation. Deep sensation was impaired in the form of
Mm-hmm.
vibration or joint
Yeah,
position,
proprioception.
yeah, or proprioception. Here, Romberg test, I cannot do it because the patient already ataxic while opening his
Ataxic.
eyes.
Mm.
So it's harmful to ask patient while he's ataxic, when he's
Mm.
opened his eyes, to do the Romberg test. Definitely he will fall. And
Mm-hmm.
they might minus you in the welfare.
Mm-hmm.
Yeah.
Okay. Whenever you have a
Yes.
ataxic patient while standing and he's opening eyes, don't ask
Mm-hmm.
him to close the eyes. He will fall and you will fail the station. Definitely. You
Mm.
got it.
Yes, sir.
Okay.
So the test was then we can do the
But,
heel to shin test with by closing the eyes.
No, he is ataxic while opening his eyes. He
No,
cannot.
when he's on the bed lying down.
Yes, you can
heel.
do the heel to shin. Yeah, sorry, I heard it other. Yeah, heel to shin can, yes, distinguish between both. Yes, you're right.
بس هو هنا intact ولا ايش؟ صح؟ He
Here,
changed it.
here it was impaired. I think Dr. Aisha didn't present the finding properly. She put mix between upper and lower, but here
Yes.
supposed to be impaired coordination. So the patient, while doing the coordination chin to over heel or heel over
Mhm.
chin, he will be ataxic or he cannot do it. It will be impaired.
Yes,
Okay.
Yeah,
if
I did
cerebellum
say
has
that
open.
when he closes the eyes, he could not do it.
No, no, even while opening the eyes, the coordination is impaired.
Yes, yeah, because of the cerebellar involvement.
If
هي
the
مثلا إذا عايزة تقول إنه التاكزيا بسبب
Yes,
السيريال كولوم افكشن،
okay,
هنا معناها المفروض تكون هيل تشين تيست انتاكت.
if you want to confirm this is dorsal column and you don't have cerebellar, you have to ask
yeah,
him
the heel should, yeah,
to close the eyes, and the one doing it while opening eyes, it will be intact. But
yes, yes,
here
the
in our
cerebellar, yeah,
scenario, yeah, the problem here in our scenario, both are impaired. So either opening or closed,
does not
the
matter.
coordination, yeah, will be impaired.
Yes, yes, sir. Yeah.
You
So
got
did
it,
I
Dr.
say?
Shaiman?
Yeah,
Yeah. Go ahead.
but I
What you?
think I said yes, but I think I said it is impaired, right, Dr. Shaima?
No, no, I think
الهيد
you
انتاكت.
said I think you said according to your finding, this patient has a mixed feature of upper motor neuron, lower motor neuron, posterior column affection. According to your finding, according to what you said, he has this finding, and according to the coordination you said, while his eyes open, it is intact, while his close his eyes, it is already impaired. So based on your finding, this patient has a feature of upper motor neuron in form of hypertonia, and features of lower motor neuron in form of hyperreflexia, and features of posterior column impairment in form of loss of
Cerebellar sign,
joints pain, joints position, and what is that?
proprioception.
Impaired the coordination.
Yes.
Yeah. Mm. That's why Dr. Shaima was confused and she gave you Friedreich ataxia as differential because you give her all the
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 yeah.
the
Yes,
mixture
yes, sir.
between both.
Yeah, yes, sir. And then we this was one of the differentials, anyways.
Yeah, yeah,
Frederick's
it's the one
ataxia
of
was,
them.
and that's why I asked her about like what if you think if it's Frederick's ataxia, what else you want me to check?
Yeah.
Um,
Okay, so let's ask Dr. Shaima, what else you want to check if you have suspicious of Friedreich ataxia? What else you have to
have to
find here? In
check
the lower limb. First, in the lower limb.
the lower
First,
limb
yeah.
for inverted champignon
No, no,
feature.
no, no. This inverted champagne for the Charcot
TNT.
Marie Tooth.
اه متأكد.
Okay,
Mm,
it's supposed to have peripheral neuropathy. Okay, supposed to have peripheral neuropathy. Friedreich ataxia will contain all of the findings: peripheral
yes,
neuropathy, dorsal column, cerebellar, and
yes,
pyramidal weakness also. So you
yes.
might have areflexia at the level of
Wasting.
the ankle, plus
Yeah,
weakness, yes, wasting, and biscavus you might have
that's
as well.
yeah.
And you
Waste.
have hyperreflexia at the level of the knee, areflexia at the level of the ankle. So
And
you have mixture
yes,
of upper and lower motor
motor.
neuron lesion.
Yes,
Plus the extra neurological manifestation like cardiac, like check, finger break check in the hand, sorry, or cataract or optic atrophy. So you have a lot of
hmm.
finding. It's mixture, but not in our case today. So our case today about multiple sclerosis. Let's talk about multiple sclerosis in investigation and clinical judgment point of view.
Sir, this case was not about multiple sclerosis as such. It was about the differentials of
Okay.
um, yeah, the differentials.
Okay,
What could you
let's
find?
count again the differential of our case today.
Yeah,
Multiple sclerosis,
yes, Frederick's ataxia,
Friedreich
subacute
ataxia,
combined,
No, I
subacute
subacute
think I
combined
combined,
think
seizure.
I think you cannot say multiple sclerosis if you said there is features of lower motor neuron.
No,
multiple
no,
sclerosis
no.
with
You can mention if
there
there
is
is
a
cerebellar.
yes,
combination of different neurons.
yes, there's
Doctor, if you have
Yeah,
cerebellar, you can have lower motor.
yeah, but
Yeah,
I don't have cerebellar here, right?
No, we have. She said
we
there's.
have.
No, no. According to her, what she said, there is no cerebellar because the patient can do.
No,
يعني
the
I,
gate.
huh?
The gate,
Wide
I said
attacks
the gate
gate.
is this
Wide
white
attacks
gate.
gate.
It acts a gate swaying on the side.
Yeah, it's this is you cannot determine the cerebellar from the gate.
No,
يعني
no. Wide attacks gate, one of the finding of cerebellar reflection.
yes, yes. But when she did the Romberg test and when she did the coordination, I think it will not go with what she said, or either she miss
Yeah,
some finding.
maybe, yeah, maybe she's missed this finding or overlook it. Forget about it. Let's talk about the differential now, and we
Yes,
will mention everything will be presented with what? Okay, doctor? Dr.
yes,
Muhammad, right? Or Mahmoud?
محجوب.
Muhi?
I,
محجوب.
Okay.
دكتور باسم
Yes.
I think إنه لو في posterior column affection ممكن يعطينا wide base gate even with patient eye open
Yes,
يعني.
yes. Attacks
high
gate.
steppage. Yeah,
It's
I
no, no, no. No, high
no,
steppage
that
with
will
peripheral
be
neuropathy.
with the peripheral neuropathy.
Yeah.
Yes.
Any ataxia, either sensory or central, will be ataxic gate. But you cannot distinguish between both from the gate. So you cannot say from the gate, this is sensory ataxic gate, or this is a cerebellar central ataxic gate. Both of them will give you the same gate, ataxic gate. How to
Hmm.
differentiate by doing the Romberg test? This is what I said. You got it, Dr. Shaima?
Yeah.
Yes.
Okay, so let's talk about everyone of our differential, what could be presented with, and how to investigate. Starting by multiple sclerosis, the patient will present with,
Yeah. It will be a central lesion.
yeah, and
So
how it will be presented as
it
upper
will be
motor,
upper motor kind
perfect,
of lesion with
and
pyramidal. Yeah,
pyramidal
it
weakness,
can have
and
hypertonia,
okay,
increased
yes, we
reflexes.
mentioned hypertonia, hyperreflexia, all these upper motor neuron. What else can be presented with? What other
Uh,
lesions? Cerebellar can affect.
Optic eye can be affected.
Optic neuritis, this is in the eyes. I'm talking in the
Yeah,
spinal cord. So you have
in the
also
limb.
in the lower, I mean in the CNS.
y- Yeah,
So you might have pyramidal weakness and
yeah,
cerebellar.
pyramidal weakness.
You can have cerebellar affection, and you might
Yeah,
have dorsal column as well,
yes,
right?
yes. Sir.
Okay. Next, subacute combined degeneration. What you can
So
add or what you can minus.
mm, we can add the peripheral neuropathy in it.
Cerebellar, sorry,
Um,
yes, subacute peripheral neuropathy. What else?
uh, so it can be sensory and motor involvement in the peripheral neuropathy,
Upper motor neuron lesion, okay,
and yeah,
and
and
dorsal
even
column
lower, yes, glove and
and
stocking kind of.
yeah, peripheral neuropathy we mentioned, and
Uh,
dorsal column infection, but no cerebellar.
no cerebellar. Yes,
Perfect. The last one is Friedreich ataxia. What the
yeah.
patient will be present?
Frederick's can be anything, sir. Frederick's
Anything,
ataxia will be like,
every
yes.
exactly anything and everything.
Mm,
The lower, the upper, the lower motor neuron lesion, the cerebellar, the dorsal column, and as you said, peripheral neuropathy. So all of them will be there. Plus the extraneurological manifestation, as I mentioned earlier. How to investigate all these disease? General
yeah.
investigation, specific
Yes.
investigation, bedside test,
That,
imaging, lastly invasive tests. Okay, let's
mm,
talk about general CBC, leukocytic counts, anemia, roll out, kidney function, liver function. All these tests you can do it as baseline. Specific
mhm.
test for each one. Multiple sclerosis. What is the specific test?
MRI. MRI for,
Okay, MRI as imaging and also specific for Friedreich ataxia.
yeah.
What is the
The
specific?
gene test.
Genetic testing, exactly.
Yeah.
And for the subacute combined degeneration, specific test.
B12 levels. And
Perfect. That's it.
yeah.
Vitamin B12 level. Okay, bedside test for everyone. What is the best or the bedside test for multiple sclerosis? Bedside test.
Bedside. for
Evoked
multiple.
potential.
Evoke potential to see.
Evoked potential.
I,
And for subacute combined degeneration, you can do what?
yeah, the walking or the Romberg's test, we can see the
You can
physical examination. We can,
neurophysiological study, nerve conduction study,
yeah.
nerve conduction study, as well as for subacute combined degeneration. You can do nerve conduction study for peripheral neuropathy, right? Because
Yes.
both of them are having peripheral neuropathy. The imaging, as you mentioned, multiple sclerosis, you will do MRI. For subacute
Mm-hmm.
combined degeneration, still you can do MRI.
Yeah, for the notes, yeah.
And for
Frederick.
for cardiac ataxia, you will do what?
For, there is nothing
Or still, you
like
can do MRI
you can
because
do
there is
MRI and
cerebellar,
CT.
yes, cerebellar lesion.
Yes. Yes.
Okay, this is regarding the imaging. The last thing, invasive. What's the invasive test you can do in MRI?
Uh,
By the way, it's
in
diagnostic one and it's also specific.
oligoclonal banding for multiple
Exactly.
sclerosis.
Yes, you will do lumbar puncture for
Yeah.
for the multiple
Multiple
sclerosis.
sclerosis.
I don't think, yeah, in Friedreich attacks, yes, no invasive test you can do.
No need here. Yes.
Okay, so this is the way how to investigate everyone. Now the management, how to manage all of them will be the same steps. Non-pharmacological, pharmacological, non-pharmacological counseling, education, multidisciplinary team approach,
Mm-hmm.
including at the top of them neurologist. Then
Mm-hmm.
physiotherapist, limb physiotherapy. If you can add also dietitian for vitamin adjustment,
Mm-hmm.
for occupational therapist if the patient needs occupational aids. That's it. Then the pharmacological option. Everyone you can mention a medication. For multiple sclerosis, medication or disease modifying agent for multiple sclerosis, DMAMS,
Mm-hmm. Yeah,
like what
the
you mentioned,
interferon
natalizumab.
beta,
Okay, interferon beta,
natalizumab,
natalizumab,
glatiramer. Yes.
and fingolimod. What is the
Yeah.
you said about natalizumab? What I should do? Screening.
Yeah. For PML, any for JC virus
Yeah, GC
because
virus, exactly. This is Dr. Shema should know. So GC virus should be screened before starting natalizumab, okay? As well as other viral infection, HIV and TB. Any biological therapy, before starting them,
for
you have to do TB, HIV, hepatitis.
mm-hmm.
For Friedreich ataxia, how to manage? Here you
It's
can
all
add
supportive.
supportive, exactly. Plus some occupational needs. Screening is very important. Family screening here you can add it as one of the important management plan step. Friedreich
Mm.
ataxia. Okay. The
Mm-hmm.
last one is subacute combat degeneration. How to treat pharmacological.
By giving the B12 in
Yes. If you
injection
have
or
folic acid deficiency, which one you will start with?
you will start again still with B12 and
Exactly.
yeah.
Yes. Don't start with folic acid, otherwise the patient will have relapse.
Yes.
Okay. Yes, we cover all
Yes.
the differential now. I'm
Yes.
done with the comments. Anyone want to add question or comment, Dr. Aisha and Dr. Shaima?
It's, I I only
Yes.
want to say, sir, because we
Yes.
know the stuff, but when you present, I like it's I just lose the confidence. What can I do? Like I was very nervous even before starting, and I don't
My
know
only
how I'm going.
advice, Dr. Shaima, Dr. Aisha, the only advice,
Yeah.
practice, then practice, then practice, then practice, then practice. That's it.
Yes.
Okay. Whatever
Mm,
you did as a course, clinical course, or you read about a book, or you
mm,
listen to a video, you have
mm,
to practice. In the exam, you are talking subconsciously. You don't have time to think. Okay.
mm,
Whatever you are trained on, you will do in the exam. You trained to present a case, so you will present the case as you are trained on. You trained how to give investigation, you will answer them in the same order you trained on. The management plan, if you are not trained to say non-pharmacological and pharmacological, non-pharmacological multidisciplinary team approach, pharmacological according to the cause, treat acute or chronic, relapse or maintenance. You will not say that unless you are trained on that. It's a matter of organizing your answer, not having a lot of information and knowledge. Okay?
Yes. Yeah, this way of presenting is all thanks to you, sir, because I had no clue how to do it, and
It's only
whatever I
practice.
did, little bit, it's
No,
all thanks to you. That's what I can say.
you're
Like
most
I had,
welcome. At any time, message me, and if you want to practice, just message me before it. Okay?
yes, yes, yes,
Yes.
sir.
We will read the comment quickly. Dr. Henry mentioned multiple sclerosis subacute, tabes dorsalis, Friedreich ataxia. Yes, we mentioned spinocerebellar ataxia as a family history. Yes, you have to mention it. Dr. Abbas, natalizumab can cause liver damage and GI upset. Yes, any medication can cause GI upset. So you can mention it. Dr. Suha, surrounding what is what WSFE? What do you mean by this? Tone, power, reflexes, hammer, reflex, plantar, reflex, clonus, coordination. Such. I would like to complete my examination by examining back, gait, upper cranial nerves, upper limb, cerebellum. Yes, exactly. This is the way how to present. Thank you, Dr. Suha. But what is the WSFA? Mnemonic for what, Dr. Suha?
I think wasting circulation.
Oh, wasting, fasciculation.
وصفة سكار W wasting S scar
Okay.
circulation
Yeah, it's
and
mnemonic. Yeah, okay. So F for what? Fasciculation, and A for
abnormal position or
Ah,
deformity.
position. Okay. Any mnemonic you are trained on, just have it, train on it, and present it whatever you are presenting. Okay. I will not interfere with any approach, but you have to be organized while presenting. Tone, power, reflex, coordination, sensation, gait, and Romberg test. This is the way how to do the presentation and to start the examination steps. Anyone has any comment or question before ending the session? Clear for all? So we will thank Dr. Aisha, Dr. Shaima. Thank you
thank you, sir.
all for the attendance today. See you tomorrow, inshallah, with the long clinical consultation day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Masking.
Mm.